Esophagitis, as the name implies, is about inflammation of the esophagus. And I'm going to show you my advanced organizer for how I remember the different causes of esophagitis. We're going to start off with esophagitis in general and the mnemonic, and then go through each of the diseases one at a time. Esophagitis, or inflammation of the esophagus, can be caused by a couple of things, and this is my list. And to remind you that one often must do a biopsy, and to do a biopsy, you do an endoscopy. You have to take a piece of the esophagus. I use this advanced organizer to remind me of the different causes. Pill-induced, infectious, and we'll talk about which infections, eosinophilic, caustic, and then either E for everything else, because this isn't a long list, or E for GERD, and that has its own lecture because it's so common. The patient with esophagitis usually presents with odynophagia. That is painful swallowing. But sometimes it may simply be dysphagia. That is difficulty swallowing. But as our advanced organizer implies, you have to take a piece of the esophagus in order to find out what it is. And you do that by doing an endoscopy with biopsy. And you will not find it surprising that the treatment is generally going to be disease-specific. But because acid reflux causes damage to the esophageal mucosa anyway, if you add on more inflammation from another cause, you can make the symptoms worse. So generally, you're going to use some sort of antacid. And which antacid you pick doesn't really matter, whether it's a PPI or an H2 blocker. But as you'll come to realize, the PPI is more often correct, and for certain diseases is the right answer. So let's start off first by talking about pill-induced. Pill-induced esophagitis is caused by the pills getting stuck. And because it's in contact with esophageal mucosa, it causes inflammation and burns the esophagus a little bit. Generally, the pill is going to pass, right, but the damage is left behind. What the patient feels is not the pill getting stuck. They feel the burning of the pill, the caustic reaction, before the pill disappears, or they feel the symptoms thereafter. The pills that are notorious for this are non-enteric-coated NSAIDs, antibiotics, especially tetracyclines, the bisphosphonates, and HIV medication, antiretroviral therapy. The patient is going to present with esophagitis. And generally in their history are going to be some of these larger pills that people have trouble swallowing. The diagnosis is made with endoscopy and biopsy. And if you happen to see the pill still sitting there, you remove it. But chances are you are not going to see the pill that's done the damage. You're going to see the resulting esophagitis, and that's it. But if they're on a culprit medication and you haven't diagnosed another cause of esophagitis on that EGD, what you need to do is remove the offending agent. And then give them time to heal. But while they heal, give them the PPI. But the most important way to treat pill-induced esophagitis is to never get it in the first place. You do that by avoiding recumbency and drinking a full glass of water with each pill. That's pill-induced. Let's move on to infectious. An infectious esophagitis can be caused by a couple of organisms. Now, really, anything can cause an infection of the esophagus, but the ones I want you to learn about are these four. It is Candida, HSV, CMV, and HIV. And the patient is going to present with esophagitis. You are going to make the diagnosis with endoscopy and biopsy, because the biopsy is going to definitively tell you which one of these it is, and sometimes you can just tell by looking with the endoscopy. And the treatment is going to be with some form of antibiotics. Which antibiotic you choose is going to correspond with each of the organisms. The reason why we coach these four in particular, because they're common, but also because you can see them generally before you do the endoscopy. See what I mean? For oral candidiasis, that cottage cheese stuff you see on the mouth you can scrape off, it's pretty easy to diagnose that. It's a clinical diagnosis. If they also have esophagitis symptoms and they have oral candidiasis, you treat it as esophageal candidiasis. So if you see oral thrush, you treat the candida with fluconazole. And this is important. Oral candidiasis can be treated with nystatin, swish, and spit. You may see patients use nystatin, swish, and swallow to treat esophageal candidiasis. But because it represents a systemic disease, you need a systemic treatment, so oral fluconazole is the right answer. Just like candidiasis, if you have herpes esophagitis, you're probably going to see the oral lesions. Painful prodrome, vesicles on an erythematous base, ulcers in the multiple stages of healing, and esophagitis is probably herpes. Of course, you can take a biopsy and see for yourself. If you suspect HSV, you treat with Val or acyclovir. Acyclovir or valacyclovir. CMV does not have a typical finding in the mouth, and you will have to do the biopsy in order to diagnose CMV. If you see CMV, it's Val or ganciclovir. And HIV is going to be esophagitis with opportunistic infections. And if HIV is causing esophagitis directly, you'll see that on biopsy. But it's also to remind you that these diseases really only happen in the immunocompromised host. Someone who's on systemic steroids or on monoclonal antibodies for the rheumatologic disease are at risk for these too. But the point being is that if you diagnose one of these, you better know their HIV status, because if they're HIV positive, they're an AIDS-defining illness. And if you have HIV, you should be started on heart. More on this in the ID lectures. It's pill-induced, infectious. We're talking about eosinophilic next. And eosinophilic is the one that's highest yield for the test. And you'll see why. Eosinophilic esophagitis is essentially an allergic reaction. It's an allergic reaction to food that causes eosinophilia in the esophagus. So the type of person who's going to get this are going to be the people who get allergic reactions. It's the A syndromes. Asthma, seasonal allergies, and atopy. That is eczema. If you see this pattern and they have esophagitis, you're pretty sure it's eosinophilic. The diagnosis is made with EGD and biopsy. What you're going to see is greater than 15 EOs per high-powered field. And this is why this is such a great test question. Because if they have not been on a proton pump inhibitor and you find greater than 15 eosinophils, the answer is to give a PPI. You treat GERD because GERD can cause eosinophilia. The next step is to treat the GERD, not the eosinophilic esophagitis. And if the trial fails, then you're going to use oral aerosolized steroids. And so there's two particular cases. There's a person who comes in with GERD symptoms who gets put on a PPI for 6 weeks, fails, then gets an endoscopy. 15 or more EOs, oral aerosolized steroids. But then there's the person who comes in because they have symptoms, they get biopsied first, that person goes on a PPI. So it's because of this little flip-flop that you can do, this becomes a great test question. And lastly, we'll talk about caustic. And caustic ingestion is covered a lot in the burn lecture in surgery. Caustic ingestion is going to occur in two patients. It's either going to be in a kid who has an accident, that is a very young kid who gets into a sink and drinks drain cleaner, or it's going to be in the adult with a suicide attempt. But caustic ingestion is generally going to be a very strong acid or a very strong base, an alkaline substance. And because they ingest the substance, that substance has a chance to burn everything on the way down. So it can cause damage to the larynx, resulting in hoarse voice or stridor. If you hear stridor, that means pending airway collapse, intubate that person prophylactically, handle the burn and the caustic ingestion later. But it can also damage the esophagus, so you'll present with drooling. And you may see some facial burns or mucosal burns from the caustic substance. The diagnosis is made by endoscopy. But you're not doing it to find out they ingested a caustic substance. You probably know that because that's why they're there, if it's a mystery, but often you don't. You do the EGD to determine the severity. If you have low severity, some mild inflammation, you can put them on a liquid diet and observe them. If it's high severity, what you're looking for in high severity is going to be strictures, really necrotic, black-looking esophagus. You keep them NPO for 72 hours and then repeat the EGD to see if they're ready to have food. But there are some things you absolutely do not do. You never neutralize the pH. If you try to neutralize a strong acid with a weak base or a strong base with a weak acid, thinking you're going to put the pH back to where it's supposed to be, what you end up doing is causing a thermophilic reaction. You burn them again, this time not from the caustic substance, but from the thermal reaction. You should not do that on the skin either. But the problem is you can't also rinse things off. And if you get a chemical on your skin, what you're supposed to do is flush it over and over and over and over and over again until it's gone. Because your stomach has limited space, you may not think to do that. So you might try to neutralize the pH. Never neutralize the pH. And never induce emesis. You might be thinking you're doing a good job by sparing the rest of the GI tract exposure, but what you do is give that caustic substance a second pass at the esophagus and the larynx, which can kill them. But I made reference to it, right? If you have this toxic chemical on your skin, you flush it with fluids. How do you flush the stomach? What you can do, if you've caught them very early on in the case, you put an NG tube and do a lavage. You flush it with water, suck it out. Flush it with water and suck it out. All right, so we've covered esophagitis in general with our mnemonic, recognizing that EGD and biopsy is key. And then we went through some of the key elements of these diseases. Pill-induced, prevent it from drinking a lot of water and staying upright as you take your pills. Infectious, link up the organism with the oral finding and the medication. Candida, fluconazole, HSV, acyclovir, CMV, ganciclovir. Eosinophilic esophagitis is the tricky one. If you diagnose it, it's going to be very clear. If they were not on a PPI, the answer is PPI. If they're already on a PPI, the answer is oral aerosolized steroids. And lastly, caustic, where the importance is on when can they start eating and what do you not do. Specifically, never neutralize and never induce emesis. That is esophagitis.